Good afternoon. Welcome to Community Conversations with OCJR. My name is Jacqueline Blocker, not Chris Steele. I'm the Engagement Director for OCJR. Thank you for spending your afternoon with us today. Oklahomans for Criminal Justice Reform is a group that advocates for responsibly and safely reducing the mass incarceration rate in Oklahoma. And we advocate for saving the taxpayer dollars and reinvesting in alternative programs other than prisons and jails. And we also would like to keep our communities and our families stronger. And one of the reasons why today we are discussing mental health resources is because this is one of the areas that more attention needs to be focused upon and more funds need to be diverted in trying to help mental health and people that suffer with mental health issues and substance abuse issues. As most advocates know that prison is not the right place for someone who's suffering with a mental health issue or a substance abuse issue. And so in light of COVID, obviously there's been more of a light shown upon these issues. And so we wanted to take today to have some amazing people here to discuss some of the mental health issues with COVID and just in general, things that are important to note about the mental health area. So without further ado, I'm going to first introduce the rest of my OCJR family, and then I will get on to our amazing panelists. So first we have Chris Steele, our Executive Director for OCJR. I don't know if you can hear me, but that's Chris down there with the mask on. And Callie Watkins, our Reentry Coordinator for Project Commutation. Colleen McCarty is our intern, our legal intern, policy intern, who just finished her last exam for law school, so we're very excited for her. And our office administrator, Elizabeth Mashburn. So let's get on to our panelists. First, we have Jacob Beaumont, the Director of the Criminal Justice Reform for Mental Health Association of Oklahoma. Jacob, if you would tell a little bit about yourself and then talk about a little bit about what you do with the Mental Health Association.
Sure, and thanks so much for making the time to host us all this afternoon. As Jacqueline said, my name is Jacob Beaumont. I'm the Director of Criminal Justice Reform at the Mental Health Association Oklahoma. And in a nutshell, I work at the intersection of behavioral health and criminal justice. By and large, my role is in project development, program management, helping design elements of the criminal justice system that afford us opportunities to provide diversion, provide treatment instead of incarceration, as well as help folks re-enter society from incarceration and combat some of the stigma that comes with past justice involvement. And I'm real happy to be here today.
Thank you, Jacob. I have Zach Stoykov with the Healthy Minds Policy Initiative. If you'll introduce yourself and tell a little bit about what you do with the Healthy Minds Policy Initiative.
Yeah, thank you, Jacqueline. As you said, I'm Zach Stoykov. I am Senior Policy Director for the Healthy Minds Policy Initiative. We were launched last year with an initial grant from the Ann and Henry Zero Foundation to be an independent, data-driven voice in mental health policy. We exist to support policymakers on data-driven, innovative policies for capacity building approaches and in the prevention of mental illness and substance use disorder in Oklahoma. I'm here speaking from really a data perspective on what some new research shows around what we can expect from COVID with regards to mental health and substance use needs in Oklahoma, and looking forward to diving into some of those numbers. Jacqueline, I think you might be muted.
Yep, I did it. Next up is Nisha Wilson, and Nisha is the Senior Director of State-Operated CMHCs and Criminal Justice Services at the Oklahoma Department of Mental Health and Substance Abuse Services. I had to read it all, but Nisha, if you would like to introduce yourself a little bit and tell a little bit before we get into everything, that would be great.
Absolutely. And thank you so much for the invitation to be a part of this. And it's a really important, timely topic right now. So I am Nisha Wilson. As she mentioned, I work with the criminal justice programs with the Department of Mental Health and Substance Abuse Services. And so we have programs that we fund across the criminal justice spectrum, from first engagement with law enforcement and diversion opportunities through the county jail systems and the courts. Many folks are familiar with our drug and mental health court programs. And then we also have staff that are housed alongside DOC staff in our state prisons to assist with reentry work for individuals with serious mental illnesses, helping assist them developing reentry plans and then engaging them in community supports as well. The other hat that I wear is I also oversee our state-operated community mental health centers. Many folks don't realize that the Department of Mental Health does have a vast network of treatment services that we contract with across the state of Oklahoma. Those are the safety net of behavioral health services in the state. And we actually operate several of those agencies. And so I oversee our 4 state-operated community mental health center safety network of services in Cleveland County in the southwest, southeast, and the northwest part of the state. So I'm here to talk about really what we can do to work on our own mental health services, help the individuals in our families, with our friends, with our coworkers, and talk a little bit about what our treatment network has really done to be creative to help provide services right now.
Great. Thank you, Nisha. And Reverend Leonard Shepard is the pastor at Peter's A.M.E. Chapel in Muskogee, Oklahoma. Reverend Shepard, you want to quickly introduce yourself, and then we'll dive on into the conversation.
Yes, again, I'm the pastor at Peter's Chapel, African Methodist Episcopal Church in Muskogee, where I take every opportunity to help reform the theology of the community in attendance in regard to mental illness, to help people to understand exactly the impact that their faith has on the access to treatment and on their inhibitions to the acknowledgement of mental illness in the community, as well as a professional counselor with the Improving Lives Company, where I am contracted in Tulsa. I service children that I see in their homes, in the community, and school-based, providing therapy, elementary school students there, and helping them to cope with life and to understand the impact of their environments that they're being raised in, that it has on them. And as I engage in that, I'm finding that there's a lot of work that we must do in Oklahoma to help turn this thing around.
Thank you so much for that, Reverend Shepard. I'm going to turn it over now to the experts and get out of the way. Nisha, if you would like to go ahead and kick it off with your discussion about the resources and how the isolation is kind of exacerbating some of the mental health issues that already are existing.
Absolutely. Thank you. So first, I just want to recognize that many of us, both personally and professionally, are absolutely worried about the impact of COVID-19, feeling a lot of uncertainty really challenged in times like this to maintain our own mental wellness so that we can help others in our communities and in our families as well. And so, you know, it's really important to recognize and name those feelings that most individuals in our current environment have some senses of insecurity that leads us to really being concerned about all areas of our life, right? And so that really comes out in terms of frustration and short attention spans, and sometimes anger, feeling on edge, feeling helpless. And I think it's okay and really important to kind of name those feelings that everyone is challenged with right now, again, both personally and professionally. But it's also really important to realize that we aren't helpless, and there are some very concrete things that we can do to help ourselves and help other people around us. Focusing on reaching out to family and friends, making sure that we stay interconnected with people, no matter what that looks like, and really trying to help recognize signs within ourselves and with others around us to help direct other people to reach out. And so, you know, it's completely normal at this point to identify and recognize concerns around your own health, the health of your loved ones around you. Recognizing changes in eating and sleeping patterns are really important. Chronic conditions and our own mental health conditions, making sure that we maintain health around all of those things. And certainly concern about increased use of alcohol, tobacco, and other substances, because a lot of times folks really rely sometimes on those substances, which leads us down a path of really not being able to maintain our own wellness when others around us. And so really the first step is really acknowledging and recognizing those own symptoms within ourselves and with others around us, and knowing that there is a safety net of services around us. So as I mentioned earlier, the Department of Mental Health and Substance Abuse Services maintains a safety network of behavioral health care across the state. And what that means is no matter where you are in the state of Oklahoma, there is access to mental health and substance abuse services nearby you, even if you don't have medical insurance, to be able to reach out and provide that. The treatment providers across that network, across the state, have been incredibly creative. They are following all CDC guidelines. They've maintained their operations for both outpatient and inpatient services in a safe way, where they are engaging people at first over the phone, on the internet, and really going through a checklist of concerns and conditions to then identify individually, is it safe for you to come into our facility and meet at a safe distance so that we can start to engage you in services? Or are there better options like providing telehealth services? You can get access to therapy services over your phone, through Zoom, through a number of different types of operations across the state. And I want folks to realize that Oklahoma is in a really, really unique position, in a strong position to be able to maintain consistent services to anyone across the state that wants access to those, because of the level of cooperation and preparedness that we had already invested in some basic infrastructure around telehealth. And so I think that's a really big point, is just acknowledging and recognizing that it's okay to feel insecure right now, but at the point that it starts impacting your ability to take care of your day-to-day activities, to take care of yourself, to take care of others around you, when you start feeling like you're having difficulty sleeping, or intrusive thoughts and concerns and anxieties that interrupt your day-to-day life, there are a lot of opportunities to reach out for those services.
Thank you so much for that, Misha. And I want all of our attendees to know that you are welcome to submit any questions that you have during this webinar, and we're going to reserve some time at the end for questions and answers, but please feel free to submit any questions that you have throughout the webinar, and we will do everything we can to get those questions answered for you during the course of the webinar. Thank you so much for that, Nisha. And next, we're going to turn it over to Zach. Thanks.
Yeah, thank you, Jacqueline, and great presentation by Nisha. It's a great
Can you hear
segue.
me back?
Yeah.
Okay.
Yeah, Jack. There might be a little technology lag happening, but hopefully everybody can hear me. So yeah, great presentation, Nisha. It's a good segue into what I'll talk about, which is some new research around how COVID is really exacerbating the mental health challenges that we've already had in Oklahoma. And Nisha, you raised a great point about just the normalcy of having a mental health challenge. And we know that the data show that 1 in 5 Oklahomans will have a diagnosable mental health condition. But when you look at even just anxiety and depression and the incidence over a person's life, it's more like 70 to 80% of us are going to have some sort of mental health challenge at some point in our lives. And certainly the anxiety around the COVID virus and the change in routine can have us feeling all sorts of things as we're sort of social isolating, and not to even mention if you or a loved one has been infected by COVID, and the stress that might come from that. So my organization, Healthy Minds, really wanted to try to quantify what we could be looking at from increased needs in Oklahoma, increased treatment needs, knowing that, we certainly know that there's a body of evidence around natural disasters and some sort of change in our routine affecting our mental health. We've seen that in any kind of disaster, say it's the Oklahoma City bombing, say it's a tornado, well after the initial physical effects are gone, the mental effects are really what we see lasting for years and years. And COVID, like any pandemic, it does have those effects as well. It is considered a natural disaster. COVID is not like any pandemic, though, in that we haven't had one quite to this scale. So some of the research around the impacts of this is a little bit just coming out now. But we do know that COVID will impact every single one of us. Unlike the Oklahoma City bombing or a tornado, COVID is a disaster that impacts every one of our lives in some form or fashion. And we know that there will be impact around that. We also know that there's a host of research and evidence around the impact of economic downturns on one's mental health. And we certainly know that the downturn resulting from COVID will likely be with us for many years. And we know that the unemployment now forecasted to result from this could reach and is reaching higher or at least equal to the 2008-2009 recession. We've seen a large increase in unemployment claims, and financial hardship is not only a major driver of mental health, anxiety, stress, and mental health conditions, but it affects our children. We know that financial hardship is the #1 most prominent ACEs, adverse childhood experience. So we really have to be looking at this problem from both the immediate effects and long-term effects on our children and prevention standpoint. But in terms of quantifying this, we did look at natural disaster histories, some studies that had been done around natural disasters showing increases in suicide, addiction, increases in general anxiety. We've seen and we looked at the history around economic downturn, in particular the 2008-2009 recession, where there was a large body of research done around the mental health impacts of that. So really starting to look at what unemployment levels we are now seeing in Oklahoma and what research is emerging nationally and came out of that 2008-2009 recession. We've come up with some numbers that we've recently released in a report that is on our website, healthymindpolicy.org. And some of those numbers are a little bit shocking, and we put this out not to say that this is a guarantee, this is what's going to happen. We put this out to say that without some increased focus on mental health and addiction treatment, without some increased focus on allowing providers to handle the increase of capacity need that we see. For example, the ODMH budget, for example, different policy initiatives that we can pursue legislatively that would increase treatment, that those numbers would be a real possibility, and that we really have to have a policy imperative around this. So I'll go into some of those numbers. Really, we had 4 key findings. One was, frankly, that hundreds of Oklahomans may die from behavioral health issues related to COVID, and deaths that would be as attributable to COVID as the infection itself. We estimated that 260 additional deaths from opioid overdoses alone and suicides could result from economic hardship. But if unemployment reaches as high as some experts project, perhaps as high as 30%, that number of deaths could reach 700. So keep in mind that is just suicide combined with opioid overdose deaths. That's not all drug overdose deaths, so that number certainly is underestimated. We also know that suicidal ideation and attempts will increase. Over our baseline in Oklahoma, we do anticipate, or where we are projecting, more than 34,000 additional Oklahomans may experience suicidal thoughts, and another 9,400 may attempt suicide over the next 12 months. Based on empirical research of past economic downturns. And again, if unemployment does reach about 30%, those numbers would go higher. We could see as many as 100,000 Oklahomans experiencing suicidal thoughts in addition to our current levels, and 30,000 additional Oklahomans attempting suicide over the next 12 months. That's very serious and very serious numbers. But those are certainly what the data and research would show. We also know that childhood mental health needs will be impacted substantially. I mentioned that earlier. We know from past pandemics that children involved in quarantines, 30% of them experience post-traumatic stress disorder, a diagnosable PTSD condition. That's not just social distancing, that is actual quarantine. But beyond that, just the fear and anxiety that's coming from parents or just seeing it happen in the world around, we do know that there's research that shows that any childhood mental health condition, the risk for any given child of developing a condition would be as high as 95%. That is certainly not to say that 94% of children will have a mental health problem. Rather, it means that the average amount of risk for developing a mental health problem across all children could increase by 94%. And then lastly, we said that unemployment and financial stress will increase drug addiction and alcoholism. We know from the research, we expect an additional 14,000 Oklahomans may develop an illicit drug use disorder, including opioid addiction, and that an additional 4,500 Oklahomans may develop alcohol use disorder. So I do want to repeat again, because a lot of folks have looked at this and said the sky is falling, and what we want to say is that this isn't cause for alarm. This is cause for doubling down on our challenges, on the solutions to our challenges. The solutions to our mental health challenges in Oklahoma may be slightly different with COVID. You might hear a little bit about how providers are going to telehealth, for example, and other things to protect themselves. But the solutions really have been there all along. We really just need additional capacity and resources to them. So my organization was really recommending a few things. One would be to look to people like the Department of Mental Health, look to the experts to develop a statewide comprehensive plan for addressing mental health in our state. That has been done. There certainly has been work done in collaboration between ODMH and the state health department. We know that, and certainly Nisha has been more involved with that than I have. But we also know that we need to be funding those efforts, and we know that right now we can expect over the next 12 months, as the infection rate even hopefully starts declining more, that the uptake of mental health treatment in our state will certainly increase at larger rates if any of this pans out. And we know that will cost money, unfortunately. We know that we're concerned certainly about the state's appropriations for the Department of Mental Health, and we would advocate for an increase in that. Although we have a severe budget crisis, we are making the argument that if we don't invest in mental health and addiction treatment, we will be perhaps prolonging that crisis because more individuals would find it harder to get back to work if they have an underlying health condition, so the economy would suffer longer. And we have a couple of specific legislative priorities that we've pushed and have advised behind a coalition that would be an imperative for a response to COVID. And one of those would be really increasing transparency around what we would call mental health insurance parity. This is the concept that if you are an individual with insurance and you are attempting to find mental health care, there can be no greater restrictions placed on you than an individual seeking physical health care payments on insurance. That is the law of the land. It is a federal law. There is a bill that is necessary in Oklahoma, however, to ensure that federal law is being complied with. That would be no cost to the state, and that bill is Senate Bill 1718. These are just some really beginning to policy solutions to head off this crisis, but we are releasing this report really just to show that some sort of policy solution is necessary and that the need will be greater.
Thank you, Zach. That was great information and great presentation. Thank you, Zach. Thank you, Nisha. Now I'm going to turn it over to Reverend Shepherd to talk about some of your experiences and challenges, and just a little bit of an overview about working with children with mental health issues, and kind of the importance of early detection as well. Thank you.
Okay. Well, as we know that the ACEs score is gives us a sum of the different types of abuse, dysfunction, neglect, and exposure to adverse events in childhood. And what we see is that here we have, in recent CDC studies in our high schools, our adolescents, from 9th to 12th grade, we're seeing that there's some 44% among females expressing depressive symptoms, and 28% are expressing suicidal ideation, compared to national averages of 41% expressing depressive symptoms and 22%. So this is a lot of our young females that are soon to be graduating and on their own out in the world. And they're already expressing mental illness. And we have likewise among the males, 20% are expressing depressive symptoms before they even get out of high school. And what I haven't found yet is a lot of studies on the smaller children. And those are the ones that I work with in the school systems. And I do applaud Oklahoma for, having therapists like myself in the schools, supporting the teachers and the school counselors. They're getting access, the children are getting access to services far sooner than what we're used to. And that's one thing that we're seeing here in Oklahoma. I see children as early as preschool age. And so when you have a preschooler come into your office upset and say, mommy went to jail last night, and we got to get her out, or mommy's boyfriend was hitting her yesterday, it's good. It's terrible to hear these things, but it's good to be in place, because what happens is when we're there in the school, then we have access to these children. And as we are making other professionals aware of the seriousness of mental illness in the children, then we get those referrals. And they're getting services that they probably wouldn't be as privy to outside of that environment. Because when families are experiencing great dysfunction, chances are you're not taking your elementary school child to see a therapist. Usually we see people reaching out to get a counselor for their child when their child is misbehaving and doing things. But we don't usually see a lot of people running in to say, hey, I want you to see my child because I'm exposing my child to a lot of things such as dysfunction and neglect and abuse. That just doesn't happen as much. But when the children are upset and they get to come to us, then we get to start early. And we know that, early recognition and treatment, as much as early prevention, is what we need to counteract the problem with mental illness in our state. It's conversations that need to be had because it's a community problem. Mental illness is a community health problem, and we have to address it. We have to have these conversations, and we have to have more people invited to the conversation from different disciplines, because we all have a different vantage point and impact in these children's lives. And that helps to communicate that this is something that happens. This is normal. The conversation must be destigmatized. And this is something that happens when we have more a variety of people involved in the conversation. As I said earlier, even as a pastor, I make sure to bring the conversation in. It's easy to infuse it into a sermon. It's easy to infuse it into a church bulletin, or it's easy to open up your doors to community organizations that are going to offer the resources and offer the conversations, because our children are in danger. Our children are in danger. As I said, I work with preschoolers, first graders, second graders, third graders on up in the elementary school. And what could easily be seen as a behavior problem when they're acting out, or as a problem when they're not able to focus on their studies, when we dig a little deeper and conversation with these children, then we find out that there are other issues. And so it's not just a behavior problem. It's not just a problem with inability to focus or concentrate, or having not been privy to good upbringing and as far as teaching social skills. No, what it is usually trauma is behind all of these problems that we see in children. And it needs to be addressed, it needs to be treated. Otherwise, what ends up happening is they grow up with this trauma, and this being the stage and the backdrop of where they're building the foundation that they're building their lives on, they're going to be the ones that are trying to self-medicate with drugs and alcohol. They're going to be the ones that are being arrested and incarcerated. This is what we are creating. We are shaping and forming this, indirectly by a lack of adequate action, and it's our product. These children are the babies of our community. They're our future. And so what we do is vital. And we've got to bring on board every resource every human resource that we have, and this is why it's significant, to professions that are not, so to speak, a mental health profession, yet have responsibility and yet have opportunity and something to add that will help us to be successful in wrapping around these children and giving them a chance at life.
Thank you so much for that, Reverend. All those points were well taken. Before we get on to Jacob Beaumont, I have a question for the panelists that I want to weigh in, because I think Reverend Shepherd, you mentioned this, and I'm sure everyone can weigh in on this. Someone's asking, will you all discuss destigmatizing mental health? Expand upon how we can destigmatize the mental health issues.
I'd be happy to chime in. Talk about it. I mean, it seems, maybe it's overly simple, but the destigmatization of conversations about mental health involve having conversations about mental health. It involves educating yourself and accessing resources so you can do some of that self-education if that's something that you're comfortable doing. And so now, and especially when I think about the Reverend's words, as we are having children who are experiencing a very deep trauma at this time, now is the time as parents to have conversations that normalize talking about mental health and mental illness, and finding ways to engage in those more often, and doing so with our friends and with our family members. More and more, I'm having conversations with people who have never talked to me about mental health in their entire lives, and they now want to talk to me about this anxiety that they're feeling, and being in a position where I can in an educated way, validate and reflect back to them that that's a perfectly normal thing to feel. It means that now, after this pandemic, because there's going to be another side to this, we can continue to have conversations about mental health outside of just the toll a pandemic takes on us all.
I would add to that, it's also important to talk about the success of treatment, that when individuals engage in services and get what they need to meet their mental health needs, people recover and live incredible lives. And so it's not a horrendous disease that people don't recover from. The success rates of treatment are incredible. The success rates for getting treatment for a mental illness, for an addiction, are absolutely incredible. And so I think that helps destigmatize it too, to realize that all of our symptoms and anxiety are on a continuum. And so it's completely, again, normal for folks to be experiencing these things. Really, the need for services comes in at the point that it starts disrupting your ability to do your daily life and your daily needs, and understanding that all that takes is reaching out to someone, getting help, and maintaining in that recovery. And so I think that's really important. The other piece too, I think, is really important to talk about is the long-term impact. And I know that's been touched on already, but looking at right now, we're still very much in crisis care mode. To meet immediate needs, immediate treatment opportunities, and really modifying what services look like. But the long-term impact of trauma, the long-term impact of potential unemployment, really significant rates of unemployment, those are things that haven't been seen before, to the extent that we're seeing them right now, and really across the board that we're seeing them right now. And so it's really going to be important to have a long-term focus on continuing opportunities for accessing care and recognizing that in our friends and neighbors, offering those services to our healthcare professionals and to our first responders, to our law enforcement, who are also really engaging individually with the community and experiencing a lot of trauma related to COVID-19 as well. And so that immediate focus right now of taking care of yourself and others around you, but also that long-term impact of understanding that being more understanding and caring for folks around us and helping bring them into services is also, I think, really important, which then ultimately helps reduce stigma long-term as well.
Thank you for that. And I'm going to ask you to just mention, I had a question pop up about first responders. Specifically, what mental health or extra mental health services being offered to law enforcement? It's kind of a two-part question. Is there more mental health services being provided for law enforcement? And is there special training for people that might be newly released that have mental health issues?
Yes, so I think the question was a two-part question. You were cutting out a little bit there, around services and helping first responders, and then also training for those entities. And so absolutely both of those, yes. In short, one of the evidence-based practices that we work with all over the state with our law enforcement partners is called crisis intervention training, or CIT training, for law enforcement officers. And that is an evidence-based practice that helps train officers to recognize a mental health crisis when they come on scene, understand how to de-escalate that, and then learning about their community resources to then make the decision to, instead of bringing someone to jail, can bring them to a local crisis center or mental health center. And so that's something that we've had in existence long before this crisis, has incredible results. I saw the question specifically about Tulsa. Absolutely, Tulsa is a partner with us in that. And so absolutely that happens and that occurs. So our outreach to law enforcement also happens on a couple of different levels. So one of those is our staff that actually does those trainings has developed really great partnerships with law enforcement agencies to really help them talk internally about their own employee counseling opportunities, their employee assistance programs, and making sure that folks, that law enforcement officers on staff understand their own internal resources should they seek to receive care through that mechanism, but also educating individuals around the services in their community that law enforcement and first responders can access as well. And so understanding what that network looks like in their local communities. And I should mention, if folks are looking for those types of resources, you can go to odmhsas.org website, or you can simply call 211 anywhere in the state, and 211 can help direct you to the local care in your community. And again, those are available for first responders, law enforcement officers, anyone in your community, friends and family, even if you don't have insurance.
Great. Thank you for that. I know there was a delay. I apologize for the delay, but I'm going to turn it over to Jacob Beaumont of Mental Health Association of Oklahoma now.
All right. So I'm supposed to kick off the conversation about how we anticipate the current pandemic kind of changing the face of mental health and service delivery, and how it will change the overall intersection of criminal justice and behavioral health. And what we've seen, and from the service provision perspective, it's been a very interesting 7 weeks for us. As at the Mental Health Association, we and a number of our sister organizations have had to completely overhaul our business model in terms of how we deliver services to the populations we serve the most. At the Mental Health Association, we take a housing first approach to service delivery, which means that we prioritize getting somebody stabilized in housing first, the best of our ability, and then do what we can to provide wraparound services to that individual so they can succeed and thrive in an environment of their own. We truly believe that getting somebody housed first is one of the best first steps you can take. And so our services really exist in 3 realms. And first, that's outreach and engagement with the unsheltered population, the service provision and the moving into the housing itself, and then taking a look at how these populations interact with other parts of the community, specifically the criminal justice elements. And so walking through that, and I think you'll see that a lot of organizations have had to adopt similar models. On the outreach front, when we're having to utilize social distancing and things like that, what we're hearing from a lot of our people on our homeless outreach team is that it's disappointing that they don't get to employ the individualized and very personal touch that they are usually able to in helping getting a person engaged with services. But we were trying to start the conversation and trying to answer the question, how do we serve the most people with the most basic needs right now? And just looking at some of our initial data, we've outreached almost 300 individuals in the last 7 weeks in Tulsa County alone to provide some basic needs that just aren't being met because there's been a restriction in access to services in Tulsa County. And so everything from medical supplies to food for their pets, if they have them, things that can turn encampments into places where they can actually shelter in place. And, moving into the service provision and housing, how we've changed the housing aspect of our, delivery model. It's been making sure that we're able to continue to process applications into our supportive housing. I believe it was quoted to me a few months back that, if everything goes right, it takes 170 plus days to go from homeless to housed. And that's if everything kind of breaks your way. And I don't think a lot of people are going to see things breaking their way during a pandemic. But our team has been really vigilant in changing how we're able to process those and get folks into supportive housing and support move-ins during this pandemic that acknowledge and allow for social distancing. So we're not able to move people into complexes, full of apartments, but we're able to move people into scatter sites site so they can actually get shelter and begin receiving services. And a big shout out to our outreach and our housing teams for that. And then at the policing itself, we're starting to see some changes and a lot of stretching. Just a few quick examples of how service delivery and law enforcement have changed. At the outset of all of this, we saw within the criminal justice system a number of shifts toward policies and practices that the reform community has been advocating for a long time that are now being embraced because they're matters of public health. So, at the outset in Tulsa County, for example, we saw a rapid movement by the Tulsa Police Department to limit the arrests of nonviolent offenders and, a lessening of individuals who were being held in pretrial detention who weren't deemed to be a threat to public safety. And so when we talk about this vicious cycle of fees, fines, and warrants that these populations tend to experience, it's often low-level incidents like this that kick these off that now have been relaxed in a number of ways, which is very promising. On a larger scale, and it's kind of my final example, early on in this process, I had a chance to be on a webinar aimed at maintaining drug court operations during a pandemic. And the messaging of the criminal justice professionals wasn't a punitive one. It wasn't like this is a time for increased testing. The message was this is a very stressful time for your participants. They're going to mess up. And in a time when you can't be administering, drug tests, now is the time to be understanding. Make space for them to self-report. How can you be less of a stressor in their lives so they can succeed and be a support to their families during this time? It was so stunning to hear. I had to dial into the next session just to make sure I hadn't misheard something. And it was exactly the same. It's, so as we see service professionals and criminal justice professionals, at least at the local level, start to try and answer the question, how do we serve people better during an incredibly difficult time? I'd be curious to hear from my other panelists how they've seen organizations or law enforcement agencies in communities that they're aware of stretch to provide services differently, and see how, if while we have this time, this added space for, to talk about compassion and reconsideration of how we police unsheltered populations or individuals with mental illness or substance use disorders. While it's been created out of a mandate for physical distance, what do we feel the likelihood is that coming out the other side of this, we're not going to see things just snap back to normal? And where do we see space for this added practice of thinking again about, how do we police somebody with a substance use disorder? How do we get that person into treatment as opposed to putting them in a jail cell and just holding them? So I sincerely hope that on the other side of this, we won't see these systems just immediately snap back to business as usual. And maybe I'll play the unusual role of the optimist here. I have a hard time believing they will. We've seen things stretch so much. It'd be hard to see them all snap back. I'd be curious to ask my other panelists if you're aware of other organizations who have dramatically changed their service delivery model, if you're aware of law enforcement agencies that have dramatically overhauled how they police these groups. With that asked, I'll shut up.
So I'm happy to jump in there. And I think I really liked your quote about how do we serve people better during this pandemic. And I'm hearing those same conversations, but those conversations now have switched to how do we serve people better, period, right? And so, I do think that we've had a lot of, in the time of crisis, immediate responses to get needs met, where we've now had an opportunity to settle into those changes that happen so rapidly, to look at it and really step back and say, are things better or worse now? Not from a perspective of the economy or our own health, those types of things, but from a systems perspective of how to engage people and get the end result that we want, which is less criminal justice involvement and more opportunities for engagement and treatment and recovery. I do think that we are seeing some things that have the potential for having an incredibly positive impact on those two priorities that I know everyone shares. So I absolutely think that we will see systems that aren't so quick to go back to the way processes and systems were before, I think there will absolutely be a long-term impact for the positive in the treatment system, which pushed many organizations to looking at not just pockets of telehealth availability, but really changing their service delivery model to be much more reliant on technology. And if you think about the impact of that for especially our rural regions of the state, and our ability to really provide holistic care through these new technology, expanded technology avenues, are really incredible. The potential to engage folks who have had limited opportunities thus far, again, in just those pockets that existed of telehealth care. I also think, though, the opportunities and the resources that have been brought into the state through federal funding opportunities, through state opportunities, through some really overnight policy changes that allowed our systems to incorporate technology, really have helped make those possible as well. I'll tell you from a treatment system standpoint, we have networks that are physically providing clients with devices so that they can access their therapist. And so we have treatment programs that are delivering tablets and telephones to people, dropping them off on their front porches and allowing them to engage in services that way. And I think those are examples of things that will continue and expand long after we're done with the public health crisis, which I do think positively impacts individuals' ability to access services.
That was great. Thank you all so much for that. We have thank you, Jacob, and thank you, Nisha. Thank you, everybody. Well, that was amazing information. And we actually have a few more questions that have come up. First, is there access to mental professionals for children in schools who have parents that have incarcerated parents? Is there a special kind of niche for that? I know that there are services provided, but is there any kind of specialty that focuses on the children of incarcerated or the children that have incarcerated parents?
I wouldn't say that there isn't. I have not come in contact with it, particularly myself. But these are questions that we would probe into in doing the intakes. And so we would be aware of incarceration and of parents, and that would definitely be integrated into the treatment plan, providing care to that child. But as far as a specific program geared just toward that, I've not heard of it myself, but there could be one.
Thank you, Robert. Let's see. At Transition House in Norman, this was required that we sit down. I think there's a comment, someone asking about I guess Misha and Jacob, that you were referring to elaborate on the changes that you think this might be on going forward basis. Some of the outreach programs being able to take advantage of technology on a going forward basis after whatever our new normal looks like after this, still being able to expand upon that and take advantage of the technology. Do you feel confident that those changes will stay in place?
I feel pretty comfortable. Now, I don't oversee our outreach, education, and prevention team. That's Dr. Hubbard on our end, and I don't want to make any promises for her. But what I will say is, she's overseen a lot of our support groups, which were ahead of this pandemic in person. And what we've seen since then, moving them virtually, the demand has actually spiked. Engagement has not gone down. If anything, we have uncovered brand new demand for these support groups to the extent where we're having to launch more of them. And that's just one example of how we're using technology to lower the barrier to access for individuals, because some folks are absolutely going to want in-person support groups with a facilitator, with people they consider parts of their family, and that's great. But I also don't see a future where we get to the other side of all this and say, hey, that virtual thing, we're not doing that anymore. I think it's too rich of a vein for us to mine in terms of being able to actually serve people better. It's incredibly cost effective on both the service providers end as well as on the participants end. And it might make it a little bit easier for somebody who's more hesitant to engage in mental health services to get involved if they're able to do it from the comfort of their living room in a relatively anonymous way that doesn't involve them stepping into another room. I know in Tulsa County, we've seen deployment of telehealth services through things like COPES, who are aimed at suicide prevention and providing mental health stabilization results through the community response team. Again, I don't think we're going to peel back on our ability to deploy telehealth, in that regard. It's the one of the rare silver linings in this situation is that we've been able to expand to serve more, and I don't think we'll shrink back to serve less.
And I would agree with that wholeheartedly. The research has always been there. The research has been there for years and years that access through telehealth services is equitable to face-to-face sitting in a room with someone. And so the treatment outcomes that you get are just as good. And we're seeing the same thing about clients really giving feedback about how much they appreciate the increased access, the flexibility of schedules, and to be able to look at alternatives in circumstances where they were uncomfortable coming to an office. So I would agree.
We're really seeing that too, just to chime in from the policy level, from how we're structuring payments and funding for mental health providers and different policy solutions for ensuring the providers can provide telehealth services without restraint of things like HIPAA, healthcare privacy. How do you protect privacy, but also provide emergency allowance for conducting telehealth services? There are some emergency rules passed in Oklahoma nationally in many states to allow some of that. And then the funding, we're seeing federal grants come left and right on funding for telehealth and expanding telehealth, not just for providers, but for individuals often, and even in rural areas. How do you expand capacity for internet coverage in rural areas? The interesting thing is COVID has actually started that conversation up in a really big way. It's been around for a long time, and the urgency is now there.
This has been such useful information. I think it's, like I said, it's critical to get that out there, not just in light of COVID, but overall. But the fact that there's been an uptick in suicide since the COVID isolation, I think it's important to highlight these issues even more so now, and to make sure that we continue to push for more programs to support mental health and substance abuse, and not turn to being more punitive in that regard, to give people support and access to the resources that they need. We only have about a minute left, so if Chris still can hear me, I'm going to close it out. I don't know if you can hear me. Chris, I think you can hear me. Well, I'll just close it out then. Thank you all so much for joining us, panelists. I want to thank you all so much for taking this time to be with us and sharing such an important information with us. Please, everyone, all the attendees, if you have any more questions, we're going to have all the resources that have been referenced on here, links to everybody on our Facebook page, on the OCGR Facebook page, along with the recording of the webinar. Chris, can you hear me and say goodbye?